My name is Jennifer Woyach. I'm a professor in the Division of Hematology, where I serve as Associate Director for Clinical Research and am section head of the CLL and hairy cell leukemia programs, as well as co-director of the Leukemia Research Program within the Ohio State University Comprehensive Cancer Center. I've been a Buckeye for a long time, starting in medical school. During my training, I locked in on hematology-oncology as a specialty pretty early during my clinical rotations, when I realized that this was a specialty where you have the opportunity to develop long-term relationships with patients and their families and intervene in a critical time in their lives to provide education, comfort, and most importantly, hope. I became interested in chronic lymphocytic leukemia, or CLL, when I started working with my mentor, Dr. John Bird, in the clinic and later in the laboratory. CLL is the most common leukemia in adults and tends to be more common in older people, although young people can get CLL as well. One of the things that drew me towards studying and taking care of patients with CLL is that at that time, the biology of this disease was becoming much more clear. And with that knowledge came the opportunity to target CLL cells with specific drugs rather than using chemotherapy, which non-specifically kills both cancer cells and normal cells. The first big breakthrough in this targeted therapy paradigm in CLL came with the introduction of a drug called Ibrutinib, which inhibits a protein called Bruton's tyrosine kinase, or BTK. What you're about to see is a complex signaling pathway called the B-cell receptor signaling pathway. The important part is that BTK is a critical part of this pathway. BTK is a signaling protein in CLL cells that's responsible for telling the cell to continue to make copies of itself and to never die. About a decade ago, it was demonstrated here at Ohio State that when you block BTK in CLL cells, it's like turning off a light switch, and the cells cease to behave like cancer cells and eventually begin to die. The way Ibrutinib does this is by forming a covalent bond with BTK, which you might remember from chemistry class forms a permanent link between the drug and the protein, thus irreversibly preventing the protein from being able to signal. In the clinic, this translated to patients who really didn't have good options for therapy, starting to take a daily pill and having their disease controlled not for weeks or months, but for years. In a short few years, these early clinical trials led to larger, more definitive studies and eventually to FDA approval. I was lucky to have the opportunity to lead the phase 3 trial in CLL patients over the age of 65 who hadn't received previous therapy, which compared Ibrutinib to standard of care chemotherapy and showed that Ibrutinib was superior, solidifying this drug's place in the initial treatment of CLL. Very early in my research career, I became interested in mechanisms by which CLL patients might develop resistance to Ibrutinib. Since we were one of the first groups to treat patients with this drug, we also were the first to see it stop working in some patients. I remember clearly the first patient we saw at Ohio State whose CLL started to come back while on the drug. We took blood from him, took it back into the laboratory, and were able to see that BTK was turned back on in his cells. And even if we treated the CLL cells in the lab with additional Ibrutinib, we were not able to block activation of the CLL cells. At that time, DNA sequencing was not as fast nor as easy as it is now, and so we teamed up with a group at Duke who had expertise in this area. We were able to perform sequencing on this patient and subsequently a few more, and we found that a mutation had developed in BTK itself that prevented the drug from binding. We then worked together with scientists at a couple of other centers who also had collected samples from patients who relapsed, and were able to show that this acquired mutation in BTK was a common mechanism of relapse. We actually were able to publish these findings only a couple of months after the drug became FDA approved for CLL, which gave us a big head start to figure out something to do for these patients. We hoped that by understanding the mechanism of resistance, we might be better able to tailor an effective and tolerable therapy for these patients. So, what does resistance to ibrutinib mean to an individual patient? At first, what it meant is that patients who were doing very well on a drug for many years, over the period of a few months, would have their lymph nodes enlarge and their blood counts drop, and begin to feel just as poorly as before they started taking the medication. And unfortunately, since we did not have effective therapies in the post-ibrutinib setting at that time, it meant that many of these early patients ultimately died of their disease. But don't worry, this isn't the end of the story. Our CLL group at Ohio State confronted this problem by performing a number of clinical trials with targeted agents in development at the time, and found only one drug that was effective in these patients. This drug, called venetoclax, became FDA approved and provided a glimmer of hope. But outcomes still weren't great, with the average remission only lasting about 2 years. Luckily, the next breakthrough provided even more hope. Through work in the laboratory, fueled by donors like you and in partnership with CLL patients willing to donate blood for our work, we were able to show that even with mutations in BTK, the B-cell receptor signaling pathway that includes this protein remains active and critical to CLL cell survival. This suggested that we could potentially still target BTK if we could find a drug that worked in the presence of the mutation. This finding actually led to an entirely new class of drugs, the reversible BTK inhibitors. Reversible inhibitors, which are actually more common in cancer medicine than irreversible inhibitors like ibrutinib, form a non-covalent bond with the target protein. In this case, they bind to a distinct site on BTK from ibrutinib. For the non-scientists, I mentioned before that blocking BTK is like turning off a light switch to the CLL cells. Let's switch that metaphor a minute to a car driving too fast down the highway. An irreversible inhibitor like ibrutinib is like stopping the car by draining the gasoline. You're not going to be able to get going again until you get some more gas. And in this metaphor, gas is BTK. A reversible inhibitor, though, is like stepping on the brakes. Both ways are going to stop the car, but if you're using the brakes, you need to keep your foot on the brake to keep the car stopped. Our group, working with companies that manufacture these reversible inhibitors, was the first to show that reversible BTK inhibitors are active in CLL patient samples that are resistant to ibrutinib. Using this mechanism, there are a number of drugs currently in early stage clinical trials that are looking exceptionally promising, including in patients who have relapsed on ibrutinib and all other available treatments. Even right now, we are seeing patients who did not have other good options for therapy having remissions going on for years with these medications. None of what I have described would be possible without a place like Ohio State, where we have a strong CLL clinical team tightly integrated with an equally strong laboratory team. Both of these teams, within the framework of this world-class cancer center, allow research to move quickly from bench to bedside and back and forth so that each time we reach the bedside, our treatments are better. So where are we headed now? The ultimate goal of all of the work that we do is to advance our care of our CLL patients to the point where we can confidently tell patients at diagnosis that their lifespan will not be shortened by this disease. That's where we are headed, and I look forward to working with all of you to make that possible. Thank you.